Could bispecific antibodies and next-generation in vivo CAR-T finally move into earlier lines of therapy for multiple myeloma? And find out why Belantamab mafodotin is making a dramatic comeback. We're live at MOASC 2026 annual meeting with Dr. Amrita Krishnan from City of Hope. In 3, 2, 1. How are bispecific antibodies shifting from later lines into earlier treatment for multiple myeloma?
So we're very excited based on the results from the MAJESTIC-3 trial, which was the combination of teclistamab plus daratumumab patients which received approval because of unprecedented results in terms of progression-free survival, median progression-free survival not reached, and an overall survival benefit compared to standard therapy being Dara-Pom-Dex or Dara-Vel-Dex, that we can use the combination with a bispecific plus daratumumab in patients with early relapses, including even at time of first relapse.
What early data convinced you that Belantamab mafodotin is making a strong comeback?
So Belantamab was approved in October 2025 based on the DREAM-7 study, which compared Belantamab, bortezomib, and dexamethasone to daratumumab, bortezomib, and dexamethasone, and again showed very high response rates, about 80%, and in patients who achieved deep responses, MRD negative responses, the median progression-free survival has not been reached. So it suggests that Belantamab does have a role in early relapse for selected patients.
How promising are the new trispecific antibodies compared with current BCMA-directed therapies?
So the trispecific antibodies, there are actually a couple. There's the one that I spoke about is a BCMA GPRC CD3 trispecific. It showed very high response rates, 100% in patients who had not been previously treated with a BCMA-directed therapy. Now, of course, that is early data, and we don't know yet in terms of the lengths of those responses, and that's what we're waiting to see now.
What advantages do the next-generation in vivo CAR-T approaches offer over traditional ex vivo products?
In vivo CAR-T has the advantage of being a quote-unquote off-the-shelf option, so you don't have to have the time for collecting T cells, manufacturing them. You don't need lymphodepleting chemotherapy. So it really is a very revolutionary approach.
Which emerging toxicities should community oncologists be most vigilant about as these novel myeloma therapies expand?
One of the things we're recognizing is this phenomenon of IEC colitis. The actual incidence is a little unclear, but we know that it can develop later post-CAR-T, generally 6 to 12 and up to 18 months after, where patients would present with severe refractory diarrhea.
If you like this video, you may also like the suggested video, Why Isn't CAR-T Therapy Revolutionizing the Fight Against GI Cancers? In the description, you will find a link to a web post companion for this video on oncologytube.com. Thank you for watching.